I'm Dr. Tritto. I am going to talk to you tonight about weight loss medications. I'm going to back up a slide. We had four previous talks, and this is our last one in the series. And the other talks are available, which I'll cover in a second. So a little bit about myself. So I am a pediatrician. I was in general pediatric practice for over 20 years. And a couple of years ago, I decided I wanted to focus only on weight management. So I left practice and went to a training program at the University of Minnesota, where I spent an entire year in pediatric weight management clinic. And I learned from some of the best physicians in the field. It was really amazing experience. Got all that knowledge and I brought it here to St. Louis and joined Evora. And at Evora, we it was originally a women's health clinic started by Dr. Lynn and has expanded over the 5 years. And now we're offering this pediatric weight management. We have myself, we have Audrey Miller, she's a dietitian, Amanda Ratz, who's a therapist and motivational coach, and Joni Sheridan, who's a personal trainer and also a pediatric nurse. So all work with kids, and we all work with kids, have experience with kids. So briefly, I'm going to go over a quick review of what our previous talks were about. That way you can refer back to them if you are so inclined. We're going to talk about when medication for pediatric weight is appropriate. We will talk about the FDA approved medications and how they work. I will explain off-label medications. And along the way, I'll also be covering side effects, costs, etc. So if you missed the previous talks, as I mentioned earlier, so they are available on YouTube on Evora for Kids. I'll have that at the end for you. We also created blog posts with some of the major points in those, and those can be found on our website. So the first talk was with Amanda Ratz, our therapist. She works with kids. She has also been a school counselor. She's really amazing. I'm sorry she couldn't be on with us tonight. She was going to join, but she couldn't make it. Second talk was about teen nutrition primarily, but actually ended up being very applicable to younger children as well. And that was with Audrey Miller. Then we had to talk about the biology and science of obesity and how psychology and environment also play a role. And then last week we talked about what it's like to come to your first visit at Evora and what my process is and how all that goes down. So previously I've shared this definition of what obesity is, and basically it's considered a disease that is chronic and recurring. And you'll notice that in this busy definition, there's nothing about lack of willpower, laziness, bad parenting. It's none of that. And I'll remind you too that when I use the word obesity here tonight, I don't use it in the office. It's not on the door. It's not on the walls. It's not on the stationery. With families, I use words like weight, shape, size, things that are not stigmatizing and much more comfortable. So everybody wants to know, like, won't my child just outgrow their weight? Are they going through a growth spurt? Well, statistics tell us that childhood obesity is really not going away. We know that 40% of adults in the US have obesity, that 1 in 5 children have it, and that 80% of those children will become adults with obesity. Among children with obesity, severe obesity rates are rising quickly, and I'll give you a brief definition of what that is in a few minutes. There are projections for 2030 that predict at least half of the US adults will have obesity by then, and the majority of today's children will have obesity by the age of 35. And severe obesity, again, is expected to increase with nearly 1 in 4 adults having it. So determining your child's weight status, or what I use and what you can also use in case you're not sure and you would like to know, maybe your doctor hasn't talked to you about it, or maybe you prefer not to talk about it in front of your doctor, in front of your child with the doctor. Now, BMI is not perfect, but it is really the best measure we have, and it does help us as children are growing and getting taller rather than looking at weight specifically. How is their weight and height proportionate? The American Academy of Pediatrics, Obesity Medicine Association, they both suggest offering medications in addition to lifestyle changes for children with obesity. And I'm going to show you how you can see where your child falls. So the CDC website has a calculator on there where you can plug in your child's height, weight, sex, plug all this in, and then it's going to give you a result. And it tells you what their BMI is, what category they're in, percentile, meaning where are they in comparison to other kids of their same gender and age. And this number, which you don't need to pay attention to too much, but I'll mention it again here in a second. So this was a 16-year-old girl, 5'3", 190 pounds. Her BMI 33.7, and she's in the obesity range. This is another example. This is an actual patient of mine, a boy who is 10 years old, 4 feet and 11 inches, and 185 pounds. And when we plot him on the chart, it tells us that he has severe obesity. And then you've probably seen one of these growth charts with your doctor in the office. But if not, I'll just give you a little explanation of what these lines are. So this on the bottom is age over time, and this is the BMI calculation over here. This dark black line in the middle is average, 50th percentile. The 85th percentile is the cutoff for the overweight range of weight. Above the 95th is considered obesity, and somewhere above the 97th is the severe obesity. So you can see that this child has been on sort of the obesity line for quite some time, and then over the last few years, it's really that curve is getting steeper, meaning she is gaining weight more rapidly, which can be, quite concerning. So what factors do we consider when we're deciding on medication? Well, one, do they have the criteria for obesity? And how far off of that 95th percentile are they? Are they gaining weight very rapidly? That can mean intervention is more necessary. Do they have a strong family history of obesity? For example, are there family members who require weight loss medications or have bariatric surgery? That's going to increase your risk for having it as an adult. Do they have really strong appetite where they never seem satisfied, always asking for food? Or are they hiding or sneaking food? Do they have what's called loss of control eating, where they really just kind of zone out and they just eat and don't really realize what they're doing? Do they have abnormal lab values, like are their liver enzymes abnormal? Are their blood sugar abnormal? Cholesterol numbers abnormal? These are all sort of reasons to consider medication. And is their mental health impaired, or their physical ability to play, run, do sports impaired? And do they have other complications like snoring or sleep apnea? I would say the more of these boxes that you check, the more likely that medication will be helpful. So, pediatric weight management, it's comprehensive with lifestyle changes for everybody. So that includes nutrition, talking about physical activity, and making behavior changes that can be helpful in regulating weight. And historically, management programs really focused on these first three pillars, but this doesn't address the underlying biological predisposition that some children may have. So that's where medical management comes in, and that's where I'm looking for medical causes of their obesity, like a hormone problem or a medication that they're on, but it also can mean prescribing medication. So generally what we're doing is we're trying to treat the underlying disease process and biology. We are trying to slow the progression of weight gain and any regain, overall improve health, and slow disease progression. For example, if they're developing prediabetes, which I see quite frequently, can we stop that from progressing on to diabetes? And of course, overall, just improving the quality of life. Some general principles that I apply when using medication is that I discuss all the options available to your child. I start with low doses and move slowly upward as needed, watching closely for side effects and for how well it's working along the way. And all the while also still working on what kind of changes can we make in lifestyle to help improve our health. So it's very individualized. We make a decision together on what seems most appropriate for your child. So we'll talk about, first we'll ask, do we want to try medication? Sometimes a family wants to try lifestyle changes first, and that's perfectly fine. But they may come in and they're already sort of doing everything right. They have a healthy eater and an active child, but maybe they just have a very strong appetite, need large portions. And second, then we decide which medication is most appropriate for the patient. And we look at, how high they are on that growth chart. How rapidly is their weight rising? Do they have complications, like I mentioned? Or do they have depression, anxiety? What other medications are they on? And what their eating behavior is like when do they eat? Do they eat a lot at night? What do they eat? How big are their portions? How strong are their food cravings? These all help me make a decision on what's the right choice for the kid. And of course, cost is important, and as always, family preference. All right, one more talk about medications in general. So we think about the risks of treating versus the risks of not treating, and the benefits of treating versus the benefits of not treating. So risks of treatment, we do have safety data, but we don't have it for years and years. We have short-term side effects that are possible, not always. And then we have long-term risks that we don't know about because we haven't been using some of these medications for long periods of time for weight management. The risk of not treating, we know what happens when we don't treat. We know that the BMI continues to go up, that we develop diseases or worsening of conditions. Our life expectancy goes down. We develop heart disease, diabetes, liver disease, increased risk of cancer, sleep apnea, and so on. So we know what happens when we don't treat. When we think about benefits of treatment, of course, we get to a healthier weight. We improve those risk factors. We improve quality of life. Unknown long-term benefits. I'm going to come back to that. And then with no treatment, the benefit is no exposure to long or short-term side effects. But something that we don't talk about, I think, enough is the unknown long-term benefits. We don't know that yet either. Like maybe treating obesity in children early can cause some remission where they don't need medications for the rest of their life. Maybe we can reset how their brain is regulating appetite while it's still developing. We don't know, but if I had to guess, this is where we're going to see more of this than we expect. Okay, I lied. One more about medications in general. Um, so managing expectations, we'll talk about what to expect, what not to expect. So lifestyle changes, again, still important. Sometimes just slowing down the weight gain or stopping weight gain is progress, especially in a growing child. So if I have an 8-year-old in front of me who weighs, oh, I don't know, 90 pounds, if that 8-year-old just stayed at 90 pounds until their height caught up, that would be okay. Like that sometimes is a great first step. Weight loss is sometimes slower when we are losing pounds. Like sometimes it's slower than we expect. Sometimes we hit plateaus, and that's normal. Um, Everybody responds differently to different treatments, so we don't know which is going to be the best treatment. I can make a good guess, but I know that sometimes we have to change and pivot. Same with dosing. And some people need more than one medication depending on how severe their weight is. And for now, we expect treatment to be long-term, but of course it can be stopped or reduced if we are in a healthier weight. All right, so I'm going to start going over in general some medications, and then we'll go in a little bit deeper on the ones that I use most frequently. So for children 12 and up, there are 4 medications that are FDA approved. The first one is called Orlistat. We don't really use this one. It's a pill that you take with each meal. It prevents your body from absorbing fat. The problem with that is the fat comes out the other end really whenever it wants to, and nobody likes that. And so we never use it, but it is approved. Trucimia is one, and I'm going to go into that in more detail. That's an oral pill. Saxenda or liraglutide, that's one of the GLP-1 receptor agonists. I'll go over that in a minute. That's an injection. And then Wegovy or Wegovy, that is another one of these GLP-1 receptor agonists, and I'll go over that in more detail as well. Also giving you kind of a general idea on costs for this group of medicines. Now, for 16 and up, there's one more option, and that is phentermine. When we're talking about FDA approval, that is. So that's a mild stimulant, decreases appetite. I'll talk about that more in a minute. And then for 18 and up, we have these other 2 medicines, Zepbound and Contrave. In pediatrics, though, we also use medications in an off-label manner. And what that means is that these are medications that were designed for other treatment of other conditions and are considered safe, but not FDA indicated for weight management. But we do know that they work. And these, again, I'm going to go over these in a few minutes, but phentermine, topiramate, and Vyvanse are the ones that I use the most, and metformin is sometimes used also. You don't have to remember all this stuff. Okay, so Qsymia. Most people didn't know that this one existed, but it's been around for some time. So phentermine is one of the ingredients in there, and that's, again, a mild stimulant, makes you feel like maybe you've had a cup of coffee in the morning, and also appetite suppressant. The other ingredient is called topiramate, and that is a medication that decreases food cravings and increases fullness. So children will eat less and still feel full. This one was FDA approved in 2022 for 12 years and up, but it's been used in adults since 2012. And I understand that soon it's going to become available in a generic form. And research studies the average weight loss using this medication was about a 10% drop in their body mass index, which is quite significant, especially when we're looking at conditions associated with weight. And also, as I quote these sort of numbers going forward, remember that this is only during the study period, and when folks are on these medications for longer periods of time, they will very likely continue to lose weight. The cost for this one is $99 a month out of pocket. I'm going to give you what the cash costs are for these medicines going forward because so many insurances are not covering them. So if you had to pay out of pocket, that would be about the most you would have to pay. It's a capsule. It's taken once in the morning. We start with a small dose, increase it slowly to keep side effects down. And these are the side effects. Topiramate. This can change the way food tastes for some people, not all. Particularly carbonated beverages can become less interesting to patients taking this, which can be very helpful if we have a child who really has a big soda drinking issue. Probably the most common thing we see is this sort of numbness or tingling feeling in the hands, arms, feet, face. It's generally pretty mild, kind of feels like when your foot falls asleep. And if it does occur, we can continue the medication. It doesn't mean that anything has gone wrong, but if it's really disruptive, then we stop using it and we move on. Other things like dry mouth and constipation can happen. Trouble sleeping if we take it too late at night. It can increase your heart rate, but in a very, very small amount. It's not usually significant. There have been reports of changes in mood, like maybe getting more agitated or feeling more depressed. And that's something we just watch for, and it's all reversible if we do see it. Not too common. And dizziness can occur as well. Because it can increase heart rate, we are just cautious if anyone has heart disease. I check with their cardiologist to make sure that it's okay, and they always tell me that it is. And then a few other conditions where you're not supposed to use it. And importantly, that topiramate, this ingredient in here, is not safe during pregnancy. In fact, none of these medications are safe during pregnancy, but this one in particular is known to cause birth defects. So we talk about that. So phentermine, so that little asterisk here means it's getting used in an off-label manner sometimes. Again, reduces appetite. It's a stimulant. It's been around since 1959. And when it was originally approved, it was for 16 years of age and older and only approved for the use for 12 weeks. And back then, we did not understand obesity like we understand it today. But because this is such an inexpensive medicine, the studies are never going to get done on long-term use for this by itself. So it is often and most consistently used for more than 12 weeks in real life, and it can be used, we use it sometimes in younger patients as well. Because there aren't a lot of studies on this, the average weight loss documented is about 4% over 6 months, but we definitely see people lose more than that. And it's only about $15 to $30 a month, depending on the dose and timing of your medications. Once again, daily in the morning. Dry mouth, trouble sleeping, heart rate or blood pressure can increase. Again, generally very minor. If someone has anxiety, it can worsen anxiety. And so depending on the severity of the anxiety, we would decide whether this is appropriate or not. Patients with heart disease, as I mentioned before, and those contraindications and so on. So topiramate, that was the other component in Qsymia. This one is also being used in an off-label manner. Decreases food cravings and increases fullness. It's FDA approved for seizures in kids as young as 2 and for migraines in kids 12 and up. That's what its original development was for. As I mentioned, it's off-label. There are not great studies on the use of topiramate by itself. Showed a 2% reduction in BMI for children, 5 to 8% in adults. Very inexpensive, $15 to $30 a month, and insurance companies almost always cover it. I think it's inexpensive enough to them that they can't be bothered to deny it. And those are tablets, again, taken once or twice a day. I talked about how food taste can change, the numbness or tingling. Some adults will complain about fatigue or mental fogginess. It's really not very common in kids. Again, mood changes. This medication has been used in the past to help with mood, but for others that maybe have real serious problems with behavior, it could make that worse. And again, totally reversible. We stop it, it goes away. Metabolic acidosis is lowering of the pH of the blood. It's possible, and we monitor for that with some lab function tests about every 6 or 12 months. There's a caution on there for if a suicidality, if a patient has had recent suicidal thoughts or attempts, then we are to just be more careful with monitoring. And again, pregnancy, like I mentioned before. Any questions so far? No? Good. All right. Yes.
No questions so far.
All right. Okay, one more off-label medication, better known as Vyvanse lisdexamfetamine. So this is a medication for ADHD. It's approved for kids ages 6 and up. And for adults, it's also used for binge eating disorder. So we know that it works on the parts of the brain that control hyperactivity, impulsiveness, motivation, and rewards. Children with ADHD are more likely to have obesity, and children with obesity are more likely to have ADHD. And we also know that children with ADHD who have their ADHD controlled with medications lose weight more easily. But we do sometimes use it for younger kids that don't have ADHD. Maybe they have some ADHD symptoms, but they haven't been diagnosed with it. And it can be quite helpful. I've had a lot of success with it. And as a general pediatrician in practice, I prescribed Vyvanse all the time for my patients with ADHD. And so I'm quite comfortable with actually evaluating and diagnosing ADHD. So sometimes I do end up finding that the child has it as part of our evaluation, and that can help with getting it covered by insurance companies. So it can decrease binge eating, as you can imagine, and it is currently being studied in younger children for the treatment of weight, even if they don't have ADHD. So that's ongoing. Out of pocket, about $100 a month, but often it's covered by insurance with a diagnosis of impulsiveness, meaning that children are impulsive around food. And but every once in a while, the insurance company will require an actual ADHD diagnosis. It's a pill. You take it once a day in the morning. If it's taken too close to bedtime, it can cause trouble sleeping. It can increase the heart rate, can make you feel jittery, it can make anxiety worse. And again, all of that is reversible if we experience it. All right. Finally, I'm going to talk about the GLP-1 medications. These are sort of the hot topic in the media and social media and everywhere we go. And we often refer to these as new medications, but as a matter of fact, they're not all that new. So the first medication in this class was approved 20 years ago. And this is just a brief little timeline to show the medications that have come out over time. This was the original exenatide, then liraglutide. So this one was more effective than this one. Then we had semaglutide, which is the same thing as Ozempic or Wegovy. These are the same. It's actually the same molecule. Um, I forgot what I was going to say about that. Oh, this one is more effective than that one. This one is once a day. This one is once a week. So that they keep getting better and better. And it was really around here where we started to really see great improvements in obesity treatment. And then the most recent one is tirzepatide or Zepbound or Manjaro, same molecule. So semaglutide or Wegovy, approved for 12 years and up in 2022. It works on the brain. It decreases appetite. It helps with fullness. It reduces food reward, reduces thoughts about food, what people often call food noise. It also works on the stomach and it slows how quickly it empties. It slows down your digestion, so you feel more full from that also. And it also improves how our insulin is secreted with response to food. In these studies, they actually looked at what were called quality of life scores. So it showed improvement in self-esteem, their physical comfort, just sort of ability to move around, social life, family relations. So more than just weight. And this one now, 17% reduction in weight. So if let's say you were 200 pounds, 17% would be 34 pounds. And that was over the course of about a year. So longer use sometimes will lead to more weight loss. We have finally gotten to a little bit of a price war between a couple of these medications. And now this one is down to $4.99 a month as of this week. It was $6.50 a month previously. It's a once a week injection with a pen type of a device. I wish I had one with me here. I would show you what it looks like. But in the office, I do have a demonstration pen. I show kids how it works. There's a teeny tiny little needle in there that's about the size of your eyelash. That's how I explain it. And you really like go over this in great detail. Side effects, include things like nausea and vomiting, burping. If you can imagine if your stomach is emptying more slowly, those things could happen. Constipation or diarrhea, injection site redness, some fatigue. And I will tell you that when used properly and used slowly and with education and prevention, these side effects usually are pretty mild. They usually occur at the beginning of a particular dose. They usually get better, and if we increase dose, then they could come back. There are a few patients who really couldn't tolerate it for some reason, had more of this nausea, vomiting type of thing. And then we would have to try something else. But the majority of kids do just fine with it. To minimize side effects, I'm seeing them every month. I'm increasing the dose very slowly, no more frequently than every 4 weeks. And we remind patients that they need to eat smaller portions, reduce the fat in the food, and eat more slowly. These are all to mitigate those side effects. And honestly, we should be doing this anyways, right? But now we have sort of a physical consequence if we don't. So it can be helpful. There are certain people that we should be more careful with, but it's not absolute contraindication. Again, pregnancy, if someone becomes pregnant, they have to stop the medication right away. There are some rare conditions that I screen for in the office that you don't have to worry about here. Liraglutide, that's in the same family. I'm not going to go into this one too much. We don't use it much anymore, but it's been used since 2019 in children starting for treatment of diabetes. It's approved for 12 and up for weight management. It's not as effective as Wegovy. You can see just a 5% BMI reduction. But the interesting thing about this one is it will probably be approved for down to ages 6 sometime soon. The data was just published on this, and the FDA is considering approval. This one is now available in a generic $340 a month. And downside also is that this is an injection every day, and the dose is increased every week if needed. Side effects similar to the semaglutide or Wegovy, but actually a bit more common with kids. Well, with this one in particular, I should say. We think it might be because sometimes patients might forget to take their shot one day and then they take it the following day. And if you have breaks in your treatment, side effects are more likely to happen. And then finally, we have Zepbound or tirzepatide. So this one is only approved for 18 and up right now, but it's being studied in younger kids. It's also can be used for sleep apnea. Again, not yet approved for 12 and up. And average weight loss for this one was 20% in adults over the course of about a year. So as you can see, these are getting more and more efficacious. The cost for this one now is about $4.99 per month. Could be up to $6.99, I suppose, depending on your dose. And again, weekly injections and doses increased every month if we need to. Side effects similar to semaglutide or Wegovy, but actually a little bit better in the GI side effect department. So less of that nausea and vomiting. It doesn't seem to affect stomach emptying like semaglutide does. Okay, so reminder, this is going to be highly individualized to your child, that there are more than one option available, that medications have been used for some time. It's not as new as we think it is. There are pediatric obesity specialists around the country that have had great success with medications, practicing for 10 to 20 years in the field. And those were some of the people that I worked with in Minnesota. And, working closely with the physician allows us to customize and adjust as needed to whatever your child needs. And remembering that this is not just about weight, this is more also about quality of life, helping my patients have control over their appetite, improving their self-esteem, and just kind of overall health. So that is a wrap. This is all the ways you can reach us. You can take a screenshot of this or just go to Evora for Kids and you can find all of it there too. But phone, email, Facebook, Instagram, YouTube, all the things. And for anybody who's considering coming to see me, I do a free 15-minute consultation, either by Zoom or you can come in and meet me. And we could just talk about, what we're about and what you need, and we can see if we're a good fit for one another.